Thank you, Sudipda, and thanks AIOS for for keeping us all together in this virtual forum. Like so, now this is how the supracoronal hemorrhage can all of a sudden can happen after kind of like inadvertent ICC. You can see the intraoperative supracoronal hemorrhage, courtesy Dr. Shubenda. So supracoronal hematoma and supracoronal effusions, so my drainage techniques. So it is a rare condition, as Dr. Sudeep Das told, that it is a rare condition defined as a collection of blood in the suprachoroidal space in between the sclera and the choroid. And the incidence varies after ocular surgery, 0.04 to 1%, and the potential space between the sclera and the choroid, that is the suprachoroidal space, is actually a virtual space, and normally it contains approximately 10 microliter of fluid. So predisposition factor reported for the development of suprachoroidal hematoma, if you consider advanced age, glaucoma, increased axial length, high incidence in myopic patient, and patient have a systemic cardiovascular diseases like hypertension, diabetes, non-phakic status, and history of vitreous loss during surgery, as well as in the suprachoroidal effusion that may be from after surgery, postoperative, like in glaucoma surgery in TRAB 1.4 to 2%, or glaucoma drainage device to 2.7 to 8%, or from the neoplasm or inflammatory condition of the eye. So intraoperatively, just after removal of the cataract, signs of intraoperative substantial hemorrhage should consider always the bulging forward of the iris diaphragm, vitreous starts swelling out of the limbal section, iris collapse out, whatever was discussing with previous talks, that collapse of iris. So sipping or prolapse of the vitreous through the wound, or easy breaking of the sutures while closing the wound. So primary in management for suprachoroidal hemorrhage or effusion, if we have to tightly close the incision, posterior sclerotomy at that infratemporal quadrant, and anterior sclerotomy, either 1 or 2 10 to 12 millimeters posterior to the limbus on either side of the superior muscle, easy to perform. So these are the situations, so indications for the surgical drainage, where when to drain the suprachoroidal hematoma after surgery. You have done the cataract, but inadvertently suprachoroidal hematoma happens. So when there is extreme pain, persistent flat anterior chamber, uncontrolled elevated intraocular pressure, retinal detachment, central choroidal effusion, and retinal vitreous incursus in the wound, or inability to deposit the intraocular contents. So post-operative, any time up till 2 weeks, it may happen. So ideal time for drainage, you have to wait for the clot lysis. Otherwise, the adequate clot lysis may not happen in cases of suprachoroidal hematoma cases. If it is effusion, anytime you can drain it. But if it is like hemorrhage, you can see the black glow or dark glow, or you can see the hematoma like situation, or you can by clinically or by ultrasonography, you can detect it is not effusion, it is hemorrhage. So it is the timing is ideal 7 to 10 days. For secondary management, you have to refer it to the VR colleagues. So this is how we are doing the it is a short animation after doing vitrectomy, and we injecting PFCL, and through the 23 gauge or 25 gauge non-valve cannula, you have to drain, you can drain the suprachoroidal blood. So coming to our practical situation where there is retained lens matter, and you can see the increasing almost like kissing choroidals, and you have to do the lensectomy and do the vitrectomy after clearing the vitreous. You can see the suprachoroidal hematoma is there. So this is the in a sutureless manner, we are draining the we are introducing trocar cannula obliquely into the suprachoroidal space and removing the trocar blade, and then after doing vitrectomy, we are injecting PFCL push from inside and suprachoroidal blood drainage from outside. You can see the tip of the cannula to the suprachoroidal space, and at the end of surgery, remove the PFCL and inject the silicone oil to have a constant endotympanotic action. Postoperatively, you can see the vision improved to 6/60. We have done the silicone removal. Ultimately, patient gain 20/200 vision. This is another case. ACIOL implantation was already done during the surgery, but there was hematoma and kissing choroidals. So even during the introduction of trocar cannula, you may face the drainage of suprachoroidal blood if the blood is extending towards the choroid, or it is towards and very much anterior ciliary body. Like now, you have to drain the suprachoroidal blood introducing trocar cannula complex obliquely into suprachoroidal space according to maximum height in the ultrasonography. Then you can see injecting PFCL from inside and external passive drainage of the blood is possible. It is not mandatory to remove all the blood because some blood may get absorbed after in postoperatively due to the natural process. Like postoperatively, you may get good picture, but silicone removal not done because of hypotony even after 6 months of surgery. This is another case of suprachoroidal hematoma in two quadrants. Suprachoroidal blood was there, and there was hyphema. I'm using AC maintainer and then draining the suprachoroidal blood from the from the space using multiple non-valve trocar cannula, 23 gauge trocar cannula, removing the trocar blade, and then cannula guided drainage of the suprachoroidal blood was possible. After doing vitrectomy, injecting the PFCL push from inside and external passive drainage of black colored, you can see dark colored blood is a suprachoroidal blood. It's not it's altered blood. So it's a quite liquefied blood, but still some blood was there. Then I removed the PFCL, injected silicone oil. At the end of surgery, after 3 months of doing the surgery, I've removed the silicone oil and planned for the gluteal implantation in this case. So if the AC support is PC support is not adequate, so you may plan for the scleral fixation of lens, either glue or glueless, sutureless scleral fixation of IOL, and patient finally gains 6/9 vision. So, another this is, you can see the upper gluteal surgery nicely retina is attached and the suprachoroidal blood is totally resolved, although the residual blood was present during the surgery at the end of surgery. But you can see during the silicone removal, it was not there, and patient is absolutely fine. Vision finally gained 6/9 vision. This is another case, hemorrhagic kissing choroidal total retinal detachment. Sometimes suprachoroidal blood is not that much, but presence of retinal detachment, it may appears to be it is a quite huge amount of blood is there. So that just see I have I did the vitrectomy and there are small anterior breaks, so I can see the disc here. So I have to inject the PFCL to for the drainage of the subretinal fluid, internal drainage, and after adequate drainage of subretinal fluid, then you can judge, you can assess the actual amount of suprachoroidal blood along with it is not that much, not that kissing choroidal because of the bullous character of the retinal detachment. It seems to be very much like it is suprachoroidal kissing choroidals. Now complete your vitrectomy and do vitreous base excision and drain the blood using the trocar cannula. This is injecting, then remove, then settle the retina and do laser. At the end of surgery, you may use silicone oil, or you have to use the silicone oil because giving the constant endotamponade effect. And postoperatively, you can see the good result. So it is another case of hemorrhagic kissing choroidal total detachment. You can finally you can see the residual choroidal blood is there. Still, patient gained some vision. So another case, vitreous hemorrhage suprachoroidal blood, and finally patient gained 6/36 vision. So in this another case, total choroidal retinal incarceration was there, but patient I have not removed the oil because of chronic hypertony, and vision was not that much logMAR vision, although the hemorrhage was resolved not completely. So another is the bad prognosis case, retinal incarceration, retinal detachment, suprachoroidal hemanoma. These are almost non-salvageable cases, but still retina appears to be okay, flat. Silicone is not removed because of chronic hypertrophy, because oil is just preventing the crisis valve-like condition. So better prognosis cases, say CH involving only one or two quadrant. Poor prognostic factors or presence of retinal detachment, kissing choroidals, or retinal incarceration. So take-home messages should be suprachoroidal hematoma, suprachoroidal effusion. So let me tell you one thing: the suprachoroidal effusion condition are really salvageable after doing this kind of choroidal drainage. You may get good results 6/9 postoperatively after glaucoma surgery. But suprachoroidal hematoma, these are the things. If it is one or two quadrant, you may get good result. But if it is definitely you will get good result after the drainage suturelessly, but using multiple cannula posterior drainage. But if it is associated with detachment or it is associated with incarceration, these are the very poor prognosis factors. So you may not get good vision, although may have a try, patient may gain some vision, but not ambulatory vision, not even ambulatory vision. So posteriorly made sutureless sclerotomies are really helpful. Multiple cannula drainage is possible to drain the blood as much as possible. PFCL is helpful to push it from the inside for adequate drainage, and use of silicone oil can give constant endotamponade If it prevents a deep bleed as well as maintain the intraocular volume, and you can maintain the intraocular like size of the patient. So far, we have managed 15 cases of supracortical hemorrhage. These are the results. So thank you for your patience hearing.